Good morning, good afternoon, good evening, everyone. My name is Keva Koch. I'm a technical officer at the Health Systems Governance and Financing Department at WHO headquarters. We've come together as per this year's conference topic to ask ourselves and discuss how we can ensure people are on board when it comes to health policy and decision-making processes. What needs to be done to transform health systems, including hospitals, to become more responsive to today's public health challenges? It requires a shift from systems designed around diseases and health institutions towards systems designed for people and with people. And one of the key elements for this transformation to happen is in institutionalizing social participation mechanisms, the topic of my presentation today. WHO has recently launched a new guidance document, the Handbook on Social Participation for Universal Health Coverage. It is particularly targeted at government actors across all levels to provide practical recommendation on the how of social participation. It's about answering the question how to more meaningfully engage with lay people, patients, caregivers, communities, and civil societies to elaborate policies, strategies, and plans that are ultimately more responsive to population needs. To achieve the noble goal of UHC by leaving no one behind, it's really about ensuring that the voices of people are heard who are traditionally less powerful and influential, in particular the most vulnerable. The next slide provides you with an overview of the handbook chapters, and these topics really came out when analyzing the large qualitative data sets based on the various literature reviews and case studies we conducted. The book follows through the different tasks which organizers of participatory spaces must reflect on when setting up and institutionalizing those structures. In the interest of time, I won't go into detail of all topics, but instead would like to focus on chapter 2 to 4. So let's start with chapter 2 on how to create an enabling environment conducive to participation. I will use the example of hospital boards, which I think resonates the most with this conference audience. First of all, let me stress that ensuring responsiveness to local needs requires a certain level of managerial autonomy, having decision-making rights at the local level, which is also often a prerequisite for setting up hospital boards. But hospital autonomy is not a blank check for managers to do whatever they like. And most importantly, it needs to be coupled with strong social accountability measures and measures to ensure alignment of hospital strategic visions with population needs. And one of these mechanisms are hospital boards with guaranteed representation of patient and community organization to meaningfully contribute to hospital strategic directions. And this brings us to the fundamental premise of this handbook, which is power dynamics. Power dynamics are ingrained in any country's political, social, and economic landscapes, and they create unequal conditions for participation because they pose structural barriers to some while increasing access to decision-making structures for others. To enable a culture of participation, we need to even out as much as possible the playing field within the participatory space, in our example, hospital board meetings. And what we mean by that is counterbalancing the inherent and ingrained power imbalances that exist in every society for purposes of that participatory space. In this chapter, we elaborate on a notion of a participatory space where patient and community representatives who are generally weaker and less powerful are empowered to the maximum extent possible to express their views without fear of reprisal. And this means, and that's actually the difficult part, a humbling of voices who are usually more influential, such as hospital managers, chief medical doctors, district policymakers, etc. Ultimately, and this is what we try to demonstrate with this book, it's beneficial to all participants, especially to those who are used to holding power and influence, as an enabling environment can act as a great catalyzer for the participatory exercise. Hence, a participatory space can really be a very potent tool to minimize the power asymmetries if, and that's a big if, designed in a way that counters formal and informal barriers for equal participation. And they are ways to lend those with less voice and agency countervailing power through the format and design of the participatory space. Starting with, and that's the next chapter, the thorny topic of representation. And this is really one of the most oft-cited concerns of stakeholders in social participation efforts, because the issue of representation is closely linked to legitimacy and credibility. The widely held notion being that if those who are a part of a participatory process are representative of whom they are supposed to represent, for example, a community, then they are also legitimate. More importantly, the results of the process are then also seen as legitimate. However, legitimacy and representativeness is something that is not an inherent quality of a person per se. It is also something that is conferred through a well-designed participatory process. And here it's really about transparency. And transparency here means being explicit about the roles, for example, of community and patient representatives on hospital boards, so that it is clear for all participants, especially to those who used to holding power and influence because of their position and expertise, why that person is here and why we need to hear, for example, from his or her lived experiences when accessing services in this hospital, or from a patient organization having long-standing experiences in working with HIV patients in this community. So by being transparent and explicit about representatives' roles, we can lend them more legitimacy and credibility. In addition, there are also other format and design elements that can largely influence the ability to effectively take on representational roles. And you can see on your screen a couple of examples, for example, moderation and facilitation techniques, speaking time, preparatory meetings, and so on. Important for institutionalized and formalized mechanisms such as hospital boards is also the question about how many seats are reserved for community and patient representatives, as they are often concerns of a tokenistic approach, meaning that they are only invited not really to contribute and influence the deliberation, but rather to tick the box for participatory processes with already pre-agreed decisions. And lastly, on capacities needed for social participation. And again, here it's about recalibrating the balance of power, which is rooted not only, but largely in expertise, knowledge, and speaking skills. We know that the quality of exchanges is largely determined by the competencies of the participants, but also by the capacities of organizers of participatory processes to enable that level playing field where participants are on an equal footing as far as possible, which allows for those more frank and fruitful discussions, which can then have a real policy influence. There are certain key capacities for social participation, which we group into three broad categories that you can see on your screen. Recognition, recognizing the added value of social participation, communication skills, and technical skills. All in all, there is still a long way to go. And I think the COVID-19 pandemic has been a stark reminder and a devastating example, bringing to the forefront the many governance issues we face in health system, including who and who has not been involved in decision-making processes. Unfortunately, civil society and communities' actions remained largely independent from the COVID-19-led response. Lived experiences and inputs from civil society have not been systematically brought into COVID-19 decision-making, which could have helped to better understand the risks of vulnerable population groups and gain more adherence to public health measures and vaccines by working with these trusted groups. And lastly, the most common ad hoc one-way nature of engagement needs to change into one which is more regular and institutionalized. It's all reason why it is so important to heavily invest in social participation mechanisms and capacities, both as to empower communities and patients and lay people, but also to build the specific skill set needed by organizers to create meaningful platform for engagement and collaboration. Within the realm of hospital governance, hospital boards can be such a platform. to foster meaningful engagement with communities, to set up and adopt strategic directions that can better respond to the evolving population needs. But it is only one example. We need a variety of participatory mechanisms at different levels and for various purposes, be it more strategic or operational. Ultimately, in order to put and be able to put the people at the center and make them a key part in the transformation towards people and patient-centered hospitals and systems overall. Thank you very much.
Welcome to our presentation looking at humanistic leadership, focusing on engagement and collaboration across healthcare, various parts of the healthcare system. My name is Dr. Dan West, and my colleague, Dr. Ramirez from the University of Central Florida. We'd also like to recognize colleagues that have worked with us from Australia, from Brazil, Colombia, and also from Mexico. A lot of our research has involved working with these colleagues in other countries and trying to replicate the research that we have started. So today's presentation looks at really healthcare leadership management competencies. We're particularly focused on essential dimension skills, which we feel represent communication skills and interpersonal relationship skills. We'll share with you some of the study data that we have come up with. And as I indicated, this really represents areas across other countries, and we'll conclude with some future directions. There's a very specific focus within our training model on communication skills. Some people refer to these as soft skills. We consider communication skill training to be an essential dimension that really affects all other domains of leadership training. We have developed a model that has actually been implemented. We've been collecting data for 10 years, and it's a model that involves graduate students, graduate MHA, Masters of Health Administration students, working with graduate counseling students, preparing videos based on real life scenarios that are put together and then evaluated, looking at very specific skills and competencies in communications and relationships. There are obviously professors as supervisors involved in overseeing all of these reviews and presentations. But again, we can have 2-3 scenarios that are used to refine the skills and make sure the students understand what skills are essential. We had some data that we've collected. On the left-hand column here, you will see certain skill sets that we're looking at, like body posture, eye contact. Do they reflect empathy? Are they able to use open-ended, closed questions? And we've looked at collecting a frequency with which students are really focused and need training in some of these areas. And so you see horizontally then across the top a year, a calendar year, but within that year, you then see some of the data that we have collected. The next table also is interesting because this is where we have also developed very specific learning objectives. And these objectives have very specific concepts that have got to be in place. And we break that down in terms of intrapersonal skills, interpersonal skills, skills that involve smaller groups, as you would find in different departmental meetings within healthcare organizations, and then larger group meetings. So that again, we can look at how these skills can cascade at different levels. The next PowerPoint that we have to share with you is cumulative data that we've pulled in from Brazil, that involves Colombia, that involves Australia, and some of the countries we work in Central Eastern Europe. And what we have consistently found is that there's 6 real key areas where people need human development skills. One is in the area of teamwork and collaboration. That goes without saying. Everything today involves the use of interprofessional relationships to work on very complex problems that are confronted in organizations. The idea that we have conflict management and, if you will, mediation skills that can be used to work our way through conflict, communication skill, and being able to listen carefully to others is a critical skill. And as was noted in the front end, this whole idea of self-awareness and emotional intelligence comes into play when we're looking at these human dimensions. Finally, I would indicate and share with you a model we've been using, which is developed and has been developed and implemented by the International Hospital Federation. It is a competency platform. What you see pictured here are the professional domains, but within each of these domains are a lot of different competencies. Our focus has really been leadership development, but focusing on these essential skills of communication and relationship management.
Well, as my colleague Dan West has referred, we use this cascading competency model that looks not only at the knowledge, skills, and attitudes, but it looks through levels of the organization: entry level, middle management, senior executives. And it also looks at minimum and maximum competencies. So, and that with pair with this idea of management development performance continuum, which, as you see, it entices and comprehends everything that goes from formal education in universities to self-learning and lifelong learning. And as you can see there, you can see all the levels of the organization, from training institute, human resources, facilities, departments, so all levels of training, and you see how all of those interrelate with each other in some way and complement each other's and basically go down the road or up the road to complete this process of management development. We've also looked at the different levels, as we mentioned, and use different types of education. Not everything can be done in a course, in a seminar, in a conference, but you have to use from entry level like observation, tutoring, grand rounds, different things, and then mid-level, maybe use some other things, conferences and study tours. And advanced level, you need to shadow somebody or coach or use some self-study courses. And that is a way that we have found to use that. And that also connects to these blending learning venues. Now it's been evident with COVID that virtual education and interaction is important, but it is really a blended idea that we use both things. And you can see here, going from higher education, different ways to blend this education, and then professional associations like IHF, international organizations that do other things, and on training, site training, mentoring, etc., to self-development and life learning activities that are in this scale of continuum. So the most important part of what we learn is that communication and other essential human skills have to be purposely integrated into other basic concepts of management. So they're not like an additional soft skill, but it's a skill that needs to be is essential to do all the other things that managers have to do. And so we need to review the materials very carefully and see how we can integrate them and look at the interpersonal and intrapersonal areas that were explained by Dan also before, to make sure that we incorporate all of that everywhere. The future directions that we're looking for is to expand our questionnaire and assessments, focus groups, and other kinds of activities that we do through more interdisciplinary teams and members of IHF and other areas in management teams, leadership, executives, etc., and to integrate reference materials and methods, applied management tools. So when people identify what is the competency that they cannot do, they can use this tool or this idea. And of course, do the appropriate venues that we just explained across the management development continuum. We thank you very much for listening to our presentation, and we hope that we can interact with all of you. We welcome your comments and participation in this study. Thank you very much.
Hello, good morning. My name is Luis Castellón. I work at the Service of Ophthalmology in the Hospital of St. John of God in Seville, a city in the south of Spain. And we're going to speak today about the pathway of the cataract surgery and what has been our approach to make a better pathway in our surgery room in our hospital. This is important. And this is so difficult as you suppose it is to perform the surgery in a Komodo's dragon. But you have to believe me, it is going to be much more difficult to manage to code with the amount of cataract patients that we are going to handle in the next coming years. And that's because the cataract is not only the leading cause of blindness all over the world, but mostly in low-income countries. But it's also, and that's true, the most frequent surgical procedure all over the world. And this is going to be even worse in the next coming years because all the baby boomers, we belong to 1960s and 1970s in as soon as 15 to 20 years, we will be needing to be going through surgeries, through cataract surgery. This is also more important today because we are right behind the pandemic or right into the pandemic still, and we have been decreased our cataract surgeries. All the surgeries have been affected by the pandemic. So who are we, what we have done, what really, I want to speak to you and to talk to you. We are in a hospital that provides the public health care to a population of 300,000 people, and we are only 12 ophthalmologists who do perform about 250 to 300 cataract procedures every single month of the year. But what we have done is we have analyzed the increase in demand, and we have set a standard of KPIs for constant improvement. That is very important. Our goal is not only to say to you that we have performed 250 or some surgeries, but also how they have done. Do the patients see better than before? How many complications and what has been the price and how has been the procedure? And what we have done is we have searched for a partner, and we have found a very good one in Alcon, which is a very well-known pharmacy laboratory with expertise in cataract surgery processes and also with a leadership in ophthalmology. And we have done a structure, a methodology of the patient pathway analysis, going from identifying problems, assessment, proposing, implementing, and then doing a follow-up, which is what I'm going to show you right now. We came up in 2019, and then we had what we thought it was perfect, 2 surgery room, 2 theaters where we did perform 6 cataract in each one of them. And the satisfaction was a little low because of the long waiting times. Also, the staff satisfaction was also low. And what we have come today is that we have the same 2 theater rooms, but we are performing 8 cataracts in each one of them, believe it or not, with an improved patient satisfaction and staff satisfaction. We have even exported this idea to another hospital where we are being able to perform cataract waiting lists in a single theater with a performing of 12 cataracts. I have to say that only dedicated to ophthalmology. And what we did really is we went through all the steps that a patient, a single one, had to do their day of the surgery, from the patient registration to patient check, even to eye dilation, and then, of course, to surgery, and then recovery and discharge. And we settled these red flags in all those places where we thought we were having problems that I didn't think we had before. But after an analysis, we found out. What we did, we changed some furniture changes, not major changes, but we did have another pre and post-op, another waiting room, and things changed dramatically. What you see right now is that it is not important only the time of the surgery, which is very important, as you know, in which is always about 16 minutes, but the total time had a variability that it was not acceptable, from 2 hours to 5 or 6 hours for every patient. And this is the valuable time where we do something, surgery or recovery or discharge, but these are non-valuable time where we don't really are doing anything to the patient. This is non-valuable time. And we have come all the way from 2019 to today in 2021, where you can see that the surgery hasn't changed much, between 60 and 17 minutes, but the non-valuable time has decreased a lot, making a lot more satisfaction. So that, in conclusion, means that we have increased the number of surgeries 33%, which is not bad. But we have done that, reducing the waiting time, and almost with the time of the surgery unaffected, and with a sharp decrease of time that is non-valuable. We have searched for those places where we can do that. How we have done it. So you can see that in 2019 up here, people were waiting more if they came to the surgery room the 6 or the 7 in the turn on that day. And the first ones didn't wait much, but then afterwards they wait. This because we didn't give the discharge to all the patients on the time, but also the dilation time was much beautiful on these ones, but it was not enough on the other ones. And the total patient time was increasing along the day. And this has changed today. And we can say that we are very satisfied, because the dilation time for the pupil makes a very more easy procedure for the surgeon. And also because the waiting time has decreased a lot, as you can see in the satisfaction results that we have after 2021. But also, and I have to step in this, we are being brave to export this idea to a different hospital where we are doing a waiting list, only the hospital only dedicated to ophthalmology, with a single room all dedicated, and where we have done a procedure much more efficient, and we are able, it is difficult, but we are being able to go through surgery in 12 cataracts, a single surgery in a single theater room. And this is what I should be speaking to you in the next year, because we are not satisfied with only improving the efficiency of the time of the pathway, but we have to know exactly, with a very collection of clinical reported outcomes, how are dealing our patients. And we are knowing right now if our patients are getting better, how much better, and how many complications they have. But we also have a patient-reported outcomes and a patient-reported experience. And we are making a crossing data between what we think is a good surgery and what the patient thinks is a good surgery. And we are becoming to know much more about what we shall be doing in the next coming years. Thank you very much.
Accreditation serves a core purpose: to set a bar that organizations need to meet, reflecting that they have met minimal standards of quality. That is true in many types of professions. Today's session will examine how one accreditor, the Commission on Accreditation of Healthcare Management Education, worked with a large global company to use an award process to encourage sustainability as an essential characteristic for future leaders of healthcare. Presenting today is Dr. Anthony Stanowski, President and CEO of the Commission on Accreditation of Healthcare Management Education. Anthony has been the president and CEO of CAMI since 2016, and under his leadership, CAMI has created a global footprint. Joining Anthony is Dr. Daniel West, chairman of the University of Scranton Healthcare Management Program. Dan has also served in the provider sector, has been a consultant to the industry, and with CAMI has served as the past board chair, past accreditation council chair, frequent site visitor, and is the current chair of CAMI's Global Advisory Council. Dan's program was a past winner of the CAMI Canon Solutions America Award, which will be the case study we will review in this presentation. So now, let me introduce Dr. Anthony Stanowski.
Today's session will cover 3 items. Number 1, Who is the Commission on Accreditation of Healthcare Management Education, also known as CAMI? Number 2, what is the CAMI Canon Solutions Award for Sustainability in Healthcare Management Education and Practice? And why did CAMI and Canon get together to create this award? And number 3, how has that award impacted the training of future healthcare leaders based on their academic experiences, specifically at the University of Scranton? First, who is CAMI, the Commission on Accreditation of Healthcare Management Education? CAMI was founded in 1968 by organizations representing professionals in public health, executives in the hospital sector, and academics teaching healthcare management. They sought to create an accreditation program that ensures that the students graduating from university programs in healthcare management would be well prepared to lead. So CAMI's mission is clear: serve the public interest by advancing the quality of healthcare management education globally. Overall, CAMI accredits 131 programs from 83 colleges in several countries. You can see that the most prevalent degree is the Master's in Healthcare Administration, followed by a Master's in Science in Healthcare Administration. We also accredit MBA programs, public health programs, and some joint degree programs. So why did Canon partner with CAMI to underwrite the Canon Solutions America Award for Sustainability in Healthcare Management Education? Well, the award recognizes the significant influence of education on creating sustainable, inclusive, and socially responsible healthcare organizations. It's an investment in the future. So here's an overview of the program and some past winning healthcare management programs.
For the past 5 years, Canon Solutions America has proudly partnered with CAMI, the Commission on Accreditation of Healthcare Management Education, to recognize distinguished graduate health programs that actively promote a holistic approach to sustainability in healthcare. Through the trailblazing efforts of a handful of highly regarded universities from across the nation, award recipients have showcased the values and impact of diversity, inclusion, and environmental education within core curricula to help shape tomorrow's healthcare leaders. The groundbreaking initiatives of past honorees have exemplified the Canon corporate philosophy of Kiyosei, which promotes all people, regardless of race, religion, or culture, harmoniously living and working together into the future for the common good. As we focus on the future, let's first take a quick look at some of the recipients of the CAMI Canon Solutions America Award for Sustainability in Healthcare Management Education and Practice.
I think this CAMI award really reflects how far our thinking has come, because we cannot just do community work without, along the way, teaching our trainees and future leaders in healthcare how to integrate delivery of healthcare with community engagement.
CAMI introduced the Canon Sustainability Award about 4 years ago as a way to recognize programs that were developing programs that had an emphasis on environmental and cultural sustainability. The Gilling School has a number of goals outlined for the next couple of years. One of them is sort of the elimination of the use of plastic bottles, having composting sites available, and also the focus on inclusive excellence. We felt like all of these things were very consistent, again, with what we are doing and really kind of reinforce what we're trying to do in the program.
Through the UW Master of Health Administration program, I have been exposed to the deep and integral connection between our population's health and climate health. That's what led Caitlin and me to co-found the Planetary Health Committee within our program's student association.
We then reached out to other Master of Health Administration programs across the country to create the National Health Administration Climate Collaboration. Together, we intend to create curriculum that focuses on the intersection of climate health and human health as an essential part of our health administration programs.
The CAMI Canon Solutions America Award showcases the importance of sustainability for provider organizations and recognizes those CAMI-accredited programs that are constantly raising the bar for healthcare education.
Continuing with our discussion on sustainable initiatives, I want to pick up where Dr. Anthony Stanowski left off in terms of the Canon CAMI Award for sustainability. I'd like to talk with you about exactly what happened at the University of Scranton when we submitted our application. The University of Scranton is a Catholic Jesuit private university, was founded in 1888, and the Master's in Health Administration program is in the Panuska College of Professional Studies, so that we're part of PT, OT, nursing, etc. The model that was used to substantiate our application was really based on the fact that the University of Scranton, as a Jesuit university, really looks at social responsibility. Furthermore, when the university talks about community, they're talking about global leadership, not just something that's happening within the United States. And the sustainability model we were putting together, we wanted to make sure that it could be replicated, and it was based on evidence that we could use to substantiate our progress. And really what we were stressing here were several program outcomes. The first outcome is we do require an administrative residency, and in that project, everyone must complete a sustainability project. And that was the case when we submitted the application. We have also had faculty-led study abroad. This is, again, our global sustainability, and that has existed for over 25 years, where we have been taking graduate students to Central Eastern Europe, to Brazil, and to other countries. We also, at the university, offered specialized training courses so that faculty could, in fact, develop sustainability courses and build it into the courses or curriculum, which is exactly what we did. The senior leadership at the University of Scranton strongly endorses the whole concept of sustainability, whether it's financial sustainability, whether it's economic sustainability, whether it has to do with social sustainability. So we were able to demonstrate the university's commitment, and then also with our community partners, which we have had for many years. These public-private partnerships are extremely important. So that's the evidence that we had to submit and use in submitting our application to CAMI for review.
Thanks, Dan. So just to review, we discussed who is CAMI. We reviewed the purpose of the CAMI Canon Solutions America Award for Sustainability in Healthcare Management, Education, and Practice, really as a way to highlight best practices and encourage excellence. And finally, we took a look at a case study that showed the impact of the CAMI Canon Solutions America Award at one program at the University of Scranton. For more information about CAMI and the CAMI Awards, you can check out the information on our website at www.cami.org/awards. Thank you very much.